So yeah, thank you all very much for coming here today. My name is Chris Dorval. I'm the director at Ocean State Recovery Center, and I'm also a person in personal recovery. So Ocean State Recovery Center is an outpatient continuum treatment of services in Johnston, Rhode Island, that offers partial hospitalization, intensive outpatient, and general outpatient treatment. We're a full service agency that offers counseling for group, individual, mental health, medication management, prescribing, and case management services, all under the umbrella of our program. We are a recovery-oriented program that is really designed to meet the individual's specific needs and where they're at. We offer both day and evening programming, and have a 24-hour a day, 7-day a week call line that you can call at any time. Someone will answer. I know that's really helpful, especially for case managers. Like, what time is a good time? Any time is a good time to call. The phone rings constantly. Steph knows because she answers it half the time. It's always ringing. So that is us. Like I said, we also have two sister locations, one in Attleboro called Emory Recovery Center, and another one in Connecticut called Recovery Services of Connecticut. So they offer the same services, and basically the same needs. So if you have any information, if you have any questions or you have anybody that you can think of in mind, our contact information is here, and you can reach out and call anytime. All right, so I'm gonna share my slides with you now, I believe. If I can find them. There we are. There we go. So I want to first start off by defining the word stigma, right? So the word stigma, this is a definition that I stole from a dictionary somewhere, and it identifies stigma as the complex set of attitudes, beliefs, behaviors, structures that interact at different levels of society and manifest in prejudicial attitudes about discriminatory practices against people. But there's something missing here that it's hard to put into words. And any of you that have ever felt stigmatized or left out or different or other in any situation know exactly what I'm talking about. There's a feeling, there's a sensation, a visceral reaction that you get when there is stigma that is pushing in your direction. And I think it's one of the biggest, for me, it's one of the biggest deterrents that we see that prevents people from getting the help that they need, whether it's in substance use, whether it's in mental health, whether it's in any form of healthcare. The look, the feeling, the sensation that they get when they walk into the agency, the office, the building, that's what inhibits people from getting the help and services they need. So when we're talking about stigma, it's not just about what we think or what society thinks or what other people think. It's how the other person interprets the feelings that are surrounded in it, that they get when they walk into your agency. And we'll talk today about different ways that we can address that, both through language, both through the way that we organize our staff and our environment, and also just the way that we interact, the questions that we ask and how we ask those questions. So that is where we're at for that. So I'm going to move on to the next one. So I want to quickly pause for a second here. We're going to talk about the disease of addiction. So this is a definition of addiction that was published by the American Society of Addiction Medicine in 2011. This is actually the short definition of addiction. The full definition is roughly, I think, 7 or 8 pages. The ASAM tasked this work group of physicians in 2007, and it took them about 4 years to come up with a definition. You give doctors 4 years to come up with a definition, and they're going to give you 7 or 8 pages. And the full definition is great. It talks about the different neuroendocrine systems and the physiological changes that happen through the disease of addiction. But the short definition that we're going to talk about here today is really, I think, all we really need to understand addiction in the context of how it interacts with stigma. But first and foremost, addiction is a primary chronic disease of the brain that affects reward, motivation, memory, and related circuitry. So obviously there's some things that stand out here. mostly because I highlighted them in red. But the things that stand out when we read this first line, right, are addiction is a primary chronic disease of the brain, right? So it's not a moral failing. It's not a bad habit. It's not a phase that someone is going through, right? It is a disease. It is recognized by ASAM as a disease. It's recognized by the American Medical Association, by National Institute of Health. It is a disease. It's protected under the Americans with Disabilities Act. It's a disease. It's also a chronic disease. And what I mean when I say chronic, and I know many of you are very familiar with this, but chronic disease means it doesn't go away. Again, it's not something that's temporary. Steph and I, see people all the time where they'll, or we'll talk to them over the phone, and they'll call us about their loved one, their friend, their sibling, whoever. And it's like they're asking if they can drop their car off at the garage to have some plugs and wires changed and maybe top off the fluids and send them back when he can hold down a job and a paycheck. And we always have to explain to folks that addiction is a chronic disease. It doesn't just go away, right? And if it's a chronic disease, it requires chronic maintenance and lifelong recovery. What's also different about addiction in terms of a chronic disease is that it has very similar rates of relapse and remission to other chronic diseases like hypertension, diabetes, asthma, right? These are diseases that don't just go away. About 40 to 60% of people will experience a relapse throughout their course of treatment. What's different is how we talk about relapse, the language that we use, the way that we respond or react to a relapse and addiction treatment. Could you imagine, right? Think about this for a second, pause and just, put your mind into like imagination mode. Imagine if you went to your primary care doctor and they ordered some lab work, and the lab work went in, and your doctor walked up to you with the lab work in his hand. And he looked over his glasses at you and he said, "So I got your lab work back. You're dirty with sugar. Are you back on the brownies? You keep this up and we're going to kick you out." It would never happen. You would never refer to a patient's lab work as dirty, right? You would never threaten to kick them out for a symptom of their disease, having unregulated blood sugar, right? But we see it all the time in addiction treatment. We see it all the time where people are getting quote unquote kicked out of treatment or discharged from treatment because of a symptom of their disease, right? You would never hear somebody be referred to as dirty with cholesterol. You're filthy with bad cholesterol. You would never hear that, right? In primary medicine or cardiology. But in addiction, we hear it all the time. "Oh, your urine was dirty," right? And this is a huge pet peeve of mine, right? Everyone's urine is dirty. It is. Everyone's urine, by the nature of what it is human waste. It is everyone's urine is dirty. No one's urine is clean, right? But we talk about toxicology screens like clean and dirty, right? And when we do that, and I know it sounds like, minimal, but what we're doing here is we're not necessarily referring to, we're minimizing the fact that this is a disease, right? And we're talking about the person. We're talking about the reflection that their laboratory results have on that person as a human being. So it's really important that we focus on the disease of addiction and talk about it like it's a disease, because you would never hear any other chronic disease spoken about the way that we speak about addiction. It also points out here that addiction is a primary chronic disease. And what it means by primary here, it doesn't necessarily mean that addiction came first, right? What it means is that the addiction, once it is developed, is of its own entity. And what I mean by that, and why I think it's really important, is that sometimes people will tell us, and we hear this all the time, and it's oftentimes, if not all the time, very true, that my addiction began because I had surgery and I got addicted to the pain medication, or I experienced terrible trauma in my childhood and substances were the only way that I could cope with a really difficult childhood. And that is true, right? And that is very true for almost every patient that we interact with. However, why I think it's important to identify primary is that when we address the underlying causes, if we address the childhood trauma, if we address the untreated pain, if we address the, whatever it is that led to your addiction does not go away. What primary means here in this definition is that it's of its own entity. right? That addiction, even if we treat the underlying causes, doesn't mean you can go back to social cocaine use, right? It's not going to happen. I'm sorry, you've lost that. And there's an old saying in addiction treatment that once you've become a pickle, you can never return to cucumber status. You can dry out a cucumber. It's just a dry cucumber. It doesn't go back to being a pickle. And it's the same thing with a person with an addiction. If a person with an addiction develops an addiction to substances and starts using substances, they can never safely go back to moderated use. It'll always escalate back up. Now, I understand that at times we may be working, and I have in the past as well, where the goal may not be to be total abstinence at the moment. Maybe we're working towards harm reduction, or working towards reducing, we're working more towards a harm reduction model, and that's great as well. But even in that case, if a person is working on, okay, well, opioids or methamphetamine is destroying my life, but, it's not that bad if I use cannabis or if I use alcohol, that's great. And if they decide, okay, well, I haven't used methamphetamines for 6 to 7 months, the likelihood of them being able to control it if they return to use of methamphetamines or they can return to use of opioids is 0 to none, right? And so it's important that we understand that the disease, once it's there, is of its own entity. So dysfunctions in these circuits lead to characteristic biological, psychological, social, and spiritual manifestations. And I think this is really important, right? What the American Society of Addiction Medicine did here is they identified 4 areas of major dysfunction, right? Biologically, psychologically, socially, and spiritually. So we see people presenting to treatment all the time because they're in liver failure, they have elevated AST, ALT counts, that they're in kidney failure, that they're in withdrawal, that they've had an overdose, right? Some type of biological impairment that has happened as a result of their use. We see people come in all the time because they're under psychological stress, right? They can't deal with their mood, they can't deal with their behavior, their anxiety's through the roof, they're depressed, they're suicidal, or they've had passing suicidal ideations. We see people come in quite frequently for social reasons, right? I got in trouble at work, I got in trouble with the police, I got in trouble with my spouse, I got in trouble with my family, I got in trouble with my kids, right? Their social relationships get impacted. Very few and far between do we see people come in some type of spiritual existential crisis. And I want to quickly operationalize the term spirituality, because I think a lot of times, especially in the case management field, and I had heard Stephanie talking about this earlier, a lot of times in the case management field, we think about the term spirituality and we're like, I'm not getting into all that God stuff with you, right? And we bring it up to our clients and we're like, oh, what does your spiritual life look like? And they're like, oh, and typically when I ask somebody in early recovery and active addiction what their spiritual life is like, they give me 2 answers. They'll either quote some scriptural verse that they had as a child that they remembered, and or they will say, I don't really do the God thing, right? Or I'm not religious, right? Which is the exact opposite of the question I just asked, because what the term spirituality means is the general human experience of finding a sense of purpose, meaning, and value to your life, right? And one of the reasons why we hardly ever see people present to addiction treatment with this spiritual existential crisis is because their primary purpose in active addiction is to propel their addiction, is to find ways and means and covering up their use, right? It totally has compromised all their personal values because they've done things outside of their value system, typically to support their active addiction. So spirituality is a very scary place, or a very unknown place for many people in active addiction. However, if we do not attempt to support this in some way, and again, this can be through an organized practice of an organized institution of practices and principles and beliefs like religion, or it can be through something like finding a job, finding a place where you feel connected, finding a sense of purpose and community in, it could be in a community in faith, it could be in a yoga studio, it could be coaching girls soccer, it can be anything you want it to be. But we as practitioners need to be able to support people in the direction of enhancing and enriching that spiritual life, because these 4 legs, whether it's biological, psychological, social, and spiritual, all need to be supported. Because if they're not, it's like any other 4-legged stool with a weak leg, right? You'll all have probably had a stool or a chair at home that has one kind of flimsy leg, right? You don't throw it out. You kind of play stool roulette and you see how long you can sit on it until it breaks on somebody, right? We don't want to do that with someone's life, right? And so it's important that we're at least working towards identifying and supporting both their biological, psychological, and social and spiritual life in order, because whichever one is not addressed is the one that typically takes people out. Finally, it says that this disease is reflected in an individual pathologically pursuing reward and or relief by substance use and other behaviors. Now, one of the things I like to point out here is the fact that addiction is a disease that focuses on substance use, but not just substance use, right? Addiction isn't to the substance. Right? Addiction is the subsequent set of behaviors, and we're going to talk about that in the next paragraph, but it's a subsequent set of behaviors that a person develops, and the substance is part of the symptomology, right? But it's not just to the substance, it's also to other behaviors. And a lot of times I hear people talk about how addiction, I can't understand addiction. I don't know why my loved one does this. I don't know why my patient does this. I don't know why the person I'm working with is falling down this path. And I always say, we all have our own little addictions. Right. And if we can get real honest here for a second, and feel free to throw this into the chat or the Q&A, but I guarantee you some of you are going to identify with this. But how many of you have a full shopping cart on Amazon right now that you just can't wait to unload? Right. How many of you are going to go through the weekend without binge watching a TV show on Netflix, Hulu, Amazon, something like that? And if you have any good shows, please put recommendations in the chat, because I'm running out of stuff to watch. At this point right now, Amazon isn't giving me the thumbs up anymore on things. It's just giving me this look like, I don't know what else to tell you, kid. You've watched everything that we have. So please, that would help. And furthermore, if you can get through my shopping cart on Amazon and you can get through streaming services, how many of you are going to get through the entire day without looking at your phone? Whether it's for social media, whether it's for email, whether it's to scroll on TikTok for 14 hours consecutively and not know how you wound up in this deep, dark hole of random stuff. I mean, we are an addicted society, right? And I think one of the things that happens is oftentimes we marginalize addictions to certain things, right? All of us in the last several years have heard about the opioid epidemic, right? The opioid epidemic. It started because of opioid addiction. And I get asked all the time, what do you think about the opioid epidemic? And I say, we don't really have an opioid epidemic. We have an addiction epidemic, and we've had an addiction epidemic as long as people have been able to crush grapes with their feet, right? We've been dealing with the addiction epidemic for a long time. One of the things that makes the opioid epidemic differently is the people that it affects, right? And, there was no major epidemic. We didn't call it a cocaine epidemic in the 1980s when it was urban inner city African Americans, right? We called it an opioid epidemic when it started affecting middle-class white people in the suburbs, right? Yes, we do have a substance that's accessible and lethal, and a lot more lethal than other substances that we've had in the past. But we shouldn't marginalize we shouldn't focus on the substance to marginalize the disease. We should focus on the fact that we've had a disease, that we have an addiction epidemic, not necessarily a substance epidemic. So it's really important to remember that, because oftentimes folks will think that, oh, well, I was addicted to this and I'm not addicted to that. It's like saying I have Twinkie diabetes, right? No, you have diabetes. You can't just eat frosting because Twinkies were your problem, right? And so again, it's really important that we remember that addiction isn't just to a specific substance. And as a matter of fact, like I said, it's not to substances at all. We see patients all the time that trade in alcoholism for workaholism. Right, Steph? How many patients do we see that switch seats on the Titanic and they go from, okay, well, I was using cocaine every day, but now I'm into, chronic gambling, or I'm into porn, or I'm into relationships, or I'm into insert your process here, right? Whatever it is that gets me out of me. So it's really important to remember that addiction isn't just specific to a substance. It isn't specific to substances. It's the subsequent set of behavioral symptoms that we're going to talk about now. So addiction is characterized by an inability to consistently abstain. Anybody that's ever known anybody with an addiction knows that one of the first things a person will say when they're in the stages of denial will be that I can stop whenever I want to. And that's absolutely true. It's called passing out. The hard part is abstaining consistently, being able to refrain from use consistently. Or again, if we're talking about from a harm reduction approach, can you maintain a scheduled use, a use schedule, or set your own guidelines and adhere to those guidelines? I'll have people all the time that are like, well, I'm not really ready to stop drinking completely, but it's definitely causing some problems. So, we'll negotiate what is a normal or a safe, I hate to say safe, but is a less harmful amount of drinking. We'll use the NIA guidelines, right? The National Institute of Alcoholism, Abuse, and Addiction guidelines says that no more than 3 drinks in a day and no more than 14 drinks in a week for a healthy adult male under the age of 65. So I'll talk to a guy on Monday and he'll say, yeah, that sounds good to me. I'll see you next week, Chris. And I'll see him next week and I'll say, hey, how did it go with the 3 drinks a day, no more than 14 in a week? And he's like, well, I haven't drank all week. I'm saving them for Friday night. I'm just going to cash it in and have 21. And I'm like, that's like not what you're supposed to do, right? And he's like, well, and and then the justifications come. And so again, if consistent abstinence isn't the goal, it's can we consistently adhere to a self-described program for harm reduction or moderation management. Impairment and behavioral control. This has a lot to do with the limbic system part of the brain that's affected through addiction. That's where our pleasure and reward center is. That's where most of the drugs, most of the drugs and substances that we use, and our dopaminergic system is dysregulated. So that makes sense there. Craving is one of these symptoms that gets a bad rap. Craving is actually a very healthy and normal phenomenon that every single person experiences throughout the course of the day. Craving is regulated by our serotonergic and our dopaminergic system. Dopamine says this feels good, I want more. Serotonin says you've had enough. But craving is something that we all do. We crave life-sustaining activities. We crave food. We crave connection. We crave freedom from stress. We crave sleep. We crave something to drink when we're thirsty, right? Those are normal cravings. What happens is there's an old rule in neuroscience called Hebbian's rule or Hebb's rule. And the rule is that neurons that fire together wire together, right? So when we're in active addiction, a person's in active addiction and they have $20 left and they're hungry and they say, oh, I'm hungry, but I also need this $20 to get high, and they spend that $20 and they buy a substance, whatever it is, and they use it. Their brain now thinks, oh, when I'm hungry, I use, right? And we do that over and over again. We start to wire these neurons together. Same thing with loneliness, right? Oh, I don't feel, I feel disconnected. I feel lonely. Having a lot of cravings right now. And instead of reaching out and talking to a friend, right, in active addiction, many people pick up the phone and call their dealer, or they go to a bar room and they drink. And what happens is their neurons start to wire together and they start to say, oh, when I'm lonely, I drink, right? Oh, I'm tired, I drink, right? And these things happen over and over again. So whenever people tell me they're having cravings in early recovery, right, once they've made it through the withdrawal process, it's important to normalize the process that craving is a normal human phenomenon. What's happening is that we need to untrain the brain or retrain the brain that craving is for these life-sustaining activities. So whenever, instead of telling people like we want to get rid of their cravings, right, I always say, let's look underneath the craving and see what kind of biological need is not being addressed, right? What kind of life-sustaining need is not being addressed? The other symptom, the next symptom, is my favorite or least favorite, depending upon the day, and that is diminished recognition of significant problems with one's behaviors and interpersonal relationships. Now, think about that for a second. So I don't study a ton of other diseases. I know enough to be dangerous, right? I've read some books, but I don't know, besides delusional disorder, some of the dementia-related disorders, that's pretty much it. I don't know of another disease that has a symptom of the disease that's built into it to deny the existence of said disease, right? Right here. Whenever you tell somebody, oh, I think you may have a problem with addiction, it's like, nah, I don't get it. You don't understand. If you were married to my wife, you'd drink too. Or, and I hear people hide some, one of the things I hear sometimes, right? Oh, sir, I think you have a problem with substances. You have a problem with alcohol. No. It's because and then insert their ethnic or racial nationality here. And I'm like, listen, dude, I'm Irish. Don't come at me with the, we drink too much thing, because that's that's a cop out. And yes, I do understand that there's oftentimes cultural barriers and expectations that can complicate or can create an issue with seeking help or substance use. But addiction is a non-discriminatory disease. Doesn't care what color you are, doesn't care where you're from, doesn't care what your belief system is, doesn't care what your race, religion, creed, any of that is, it wants you dead. But the disease of addiction has the symptom built in to deny that this actually exists. I'll give you a great example. So I was working with a guy, I don't know, like 8 or 9 years ago. He had gone the wrong way down 95 in Providence on his way home. He was intoxicated when it happened. He was arrested, and he was sent for an evaluation for DUI, a substance use evaluation following his DUI. So after about 5 minutes of interviewing him, was able to gather enough information to say, we're probably heading towards a substance use disorder here. And so I brought it up to him. I said, I think we may be, you might be dealing with like an alcohol use disorder here. You may be struggling with a little bit of an addiction. And he goes, no, you don't get it. And I said, please enlighten me, And he said, see, the thing is, I grew up in the city of Providence, now in the Atwells Ave area. And when I was a boy, you used to be able to take a left over here and you get right from downtown right to where I grew up. And I said, And he goes, so like 25 years ago, when they redesigned the on-ramp over here and they built this mall and all these fancy highways, they kind of screwed up. And I said, excuse me? He said, yeah. So I didn't do anything wrong. It's just they designed the highways wrong like 20 years ago. And so I'm hearing this and I'm like, my initial reaction is, this guy's full of it, right? Like this is your defense. Like, this is amazing. And so my initial reaction was something's wrong here. But then I remembered that this is what the disease does, right? It totally minimizes problems in our life and our behaviors. Oh, there's no problem with this. I just went the way the highway should have been done. So rather than try and directly confront him, right? Rather than try and beat him over the head or laugh at him for how silly of a defense this is, I get in the boat with him and I say, that's a pretty interesting theory. How are we going to fix this? And he now looks at me like I need an evaluation. And he's like, what do you believe in this? And I'm like, no, I think you've got an interesting point here. Maybe we should. So as we start talking about 5 minutes into it, after us trying to spitball ideas on how we're going to take on the state and the attorney general and all of these other people, he said, I probably got to stop drinking if we're going to do all this. And I said, hey, there we go. Right. So what happened was, instead of directly confronting this, right, instead of trying to push against a symptom, we have to recognize denial, diminished recognition of significant problems, or what we call denial, resistance, or ambivalence, is just a symptom of the disease. Finally, as I mentioned earlier, dysfunctional emotional response, right? A dysfunctional emotional response presents from, again, the dysregulation of the limbic system and also the inhibition of the prefrontal cortex, the part of the brain that makes rational, logical thinking, is typically inhibited by substance use. The emotional part of our brain and our limbic system is oftentimes more dysregulated because that's where our pleasure and reward center is. So if you slow down the part that makes rational, logical decisions and kick up the part of the brain that makes emotional decisions, well, it speaks for itself. Finally, like other chronic diseases, addiction often cycles in relapse and remission. Without treatment or engagement, recovery activities, addiction is progressive and can result in disability or premature death. So it's always important to point out that not all use is addiction, right? Not everybody who picks up a substance at some point during the day is addicted to it. But all substance addiction starts with use, right? And it's a progressive illness. So yeah, maybe it's not that bad yet. Right. It's a progressive illness. It gets worse. And I've seen it. And Steph, can attest to this. We use this in our medical records. Whenever a patient comes in, we take a photo. And Steph, how many times do we have patients that come back and we talk to them about, like, look at your photo from last time you were here and look at your photo now. Right. Yeah. I don't know if you have anything you want to add to that, Steph, but I mean, just that simple practice of being able to communicate with people that, like, this is getting worse.
Yeah. And I think sometimes it gets away from people. They don't realize just in their appearance and in the way that things have kind of deteriorated over time with their families or just in their lives and how it has eaten away at what they even had the last time they were there. It gets significantly worse. It never gets better.
Yeah, it's progressive and it gets worse, right? I've yet in the 12 years I've been working in this industry had someone come back and say, hey, I just wanted to let you know I went back to using and my life got exponentially better. Yeah. Typically if people are lucky enough to make it back, we always hear how bad it was, how awful it was, and they're lucky to be alive. So one of the first and probably the most important thing that we can do to address stigma is the language that we use. right? So on the left, or I believe it's your left, right? It's my left. You'll see stigmatizing language. On the right, you'll see what is more recovery-oriented language. So first and foremost, and you already heard me talk about this, clean, right? And you'll hear people identify themselves like this at times in meetings or in your office, and they'll come in and they'll talk about, hey, I've been clean for this long, or I'm clean for that long. And sometimes it's a sense of personal empowerment. That they've been clean for that long, but as healthcare professionals, we should hold ourselves to a higher standard and use the words or the term in recovery, right? They may feel comfortable using that, but we should use a more recovery oriented language, right? And the reason is when we're using recovery oriented language, we're being strength based, we're focusing on the positive. And just because they use that language doesn't mean we have the right to use it, right? One of my best friends is a trans man, and he will call himself queer, and he's like, but don't you say it to me, right? Because it hurts when it comes from you, but I can say it about myself because it's empowering. I'm taking it back. And it's the same thing for people in active addiction, right? He'll say, that they may feel good about being called clean, but if we call them clean, what they hear is the underlying connotation that existed before, which is prior to this, you were dirty. And we're not talking about you could use a shower and a change of clothes, but we're talking about your core characteristics of what made you a person were not clean or were dirty. And so it's really important for us to focus on using the recovery-oriented terminology. Same thing with the term addict and alcoholic. It can be empowering for people to call themselves that, but it can also be disempowering, and it can also, we never know if us using that term is going to disempower someone else. So I always focus on, this is a person in recovery, and they may say, hey, my name's Tim, I'm an addict. Well, how long have you been in recovery? Right. And so even though I'm not using the exact same word, I'm using the exact same way to identify them, just using a strengths-based perspective. Even the term relapse prevention, this is one thing I get on, especially with a lot of my clinical friends, is, relapse prevention is an evidence-based practice. And I'm like, yeah, but it sounds bad, right? Because what relapse prevention does is focuses on the inevitable negative instead of recovery maintenance, right? Recovery maintenance focuses on taking the good thing and maintaining it and having it last longer. A few years ago, the DSM focused on removing this language, but the word substance abuse and dependence, right? And focusing from substance abuse and dependence to focusing on the term substance use, right? Because what we may consider abuse or dependence, these things that, again, negatively connotate the person's use of substances, they may look at as, this is the only way I could survive. Right. I grew up in a terrible childhood. I had a terrible upbringing. I was in excruciating pain. I was human trafficked, and you're going to pathologize what I did to survive. Right. And so using the term substance use as opposed to more negative terms like abuse and dependence. You already heard my spiel on dirty and clean urines. Right. Everyone's urine's dirty. Right. We should talk about urine as if it is a screen, any other test. Right. It's positive or negative. And this sometimes requires education. I remember a client came to me one day and he's like, oh, my urine's going to be dirty. And I'm like, okay. And I read the results and I was like, no, it's negative. And he's like, oh, that's not good. And I'm like, no, negative is good. And he's like, really? And I'm like, yeah. So in this case, negative is good. You want it to be negative. And he's like, oh, okay. And then I'll tell another client, oh, your urine was positive. He's like, positive, that's a plus, right? I'm like, well, not in this case, right? So it may require a little bit of education, but we should talk about screens the same way we would with any other screen. It's positive or negative, not clean and dirty. When someone takes a pregnancy test, we don't say, hey, you're dirty with a baby or you're clean with a baby, right? Like it's either positive or negative. It is what it is. Illegal drugs. And this is an interesting one. So a colleague of mine at Rhode Island College a few years ago, who's a sociologist, did a study on what's the difference between illegal drugs and recreational drugs. Anyone have any idea? And feel free to put this in the chat on if they could, as a guess to what the difference between illegal or recreational drugs is. Socioeconomic status of the user. Rich people use recreational drugs, poor people use illegal drugs. It's the only difference, right? And so rather than label the drugs, whether they're illegal or recreational, just call them what they are. Call them a substance, right? Crazy, that's another word that gets thrown around a lot, right? And so, rather than looking at, again, the term crazy is very pathological, right? Rather than that, can we look at that person as being sick or ill? And then always talk about the person first, as opposed to the diagnosis first. So don't say, you know, the addicts that I work with, or the bipolars that I work with, or the heroin addicts, or the cocaine users, or the alcoholics, right? The people with a cocaine use disorder, the people with a substance use disorder, the people with bipolar. When we treat the person first, when we use the language person first, we remember that we're treating people. When we use the diagnosis first, we minimize people into widgets, and we minimize them into pathology, and we minimize them into symptoms, and we're not talking about people. And when we lose that connection, we really lose what we do. So I want to pause here for a second, just to check in. Liz or Maureen, I don't know if there were any questions that have come up along the way.
No questions right now, Chris.
Okay, excellent. I'll keep on going. So I want to quickly talk about, you know, we talked about stigma, we talked about addiction. What is recovery, right? And so, Steph, I don't know if you want to take this from here and kind of give this definition, but then also talk about what recovery means to you.
Okay. So the definition I have is recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. Absolutely, I have lived this. I came into Ocean State Recovery on September 14th in 2021. And when I came in, I was broken. I needed a way to figure out my life. And this absolutely, this program, absolutely, gave me, kind of a blueprint on how to live. My mental health, physical health, and I'm still working to reach my full potential, but yeah. But and it is an everyday process. It's every day.
It is. And I think one of the things that makes recovery different than abstinence, or even the word sobriety, or other terms that you'll hear in reference to recovery, is that recovery is uniquely individual, right? Everybody's recovery looks different. I have a good friend out in Minnesota, and we'll talk every once in a while. And he'll tell me what's going on in his life. I'll tell him what's going on in my life. And at the end of a conversation, well, he'll always say to me, but that's my recovery. Don't you try it, right? Because his recovery is substantially different from the way that I live in my life in recovery. There are some similarities, but we've just taken two different trajectories. Neither of us is wrong. It works for us, right? And why it's important to have recovery that's individualized to you is if you try and live someone else's life, it's never going to work, right? You need to find what works for you. What I do for my daily recovery, and you know, now looks substantially different than what it did 15 years ago when I stopped using. My recovery today, in 15 years in the future, it's going to look substantially different because we change, right? But recovery, as Stephanie mentioned, is an ongoing developing process, and we're constantly trying to reach whatever our potential is, right? And you know, and it's important that it remains personal and individual to us. SAMHSA has identified 4 major dimensions that support a life in recovery. And you'll notice they kind of run congruent with the things that we mentioned earlier, the 4 areas of dysfunction, right? Health, home, purpose, community, right? Biological, psychological, social, and spiritual, right? So these 4 areas are what support a life in recovery, right? Because these are the areas that support, that are affected by the dysfunction of the disease of addiction. These, you know, this is, you know, kind of a little bit more on those, you know, what health means, what home means, the purpose, right? Meaningful daily activities, job, life, to the community, relationships, social networks along that line. So I want to quickly talk about the backbone of stigma. So these are 5 major areas that have been identified as the what holds stigma together in people's personal value beliefs. So first is issues with trust in intimate settings such as the family. Now it makes sense why a person who's living in active addiction loses trust in the family and other intimate settings, because unfortunately at times during active addiction we do untrustworthy things, right? We've been dishonest, and it's typically because, you know, one, how we support or how people would support their disease, but also how people would hide their use out of shame, right? And so trust is going to be compromised. And I always try to normalize this for people that, hey, it's okay, right? You know, people aren't going to trust you right away because you've done some untrustworthy things, but we can work to rebuild it, right? Also, you know, because of the way that, you know, one of my mentors pointed out to me once that trust is gained in thimbles and lost in buckets, right? We get little bits of it back every time we do something trustworthy. But the minute we do something untrustworthy, we knock over the bucket and it spills all back out. So it's really important for us to understand that rebuilding trust is a process. It's also important if you do any work with families, or if you do work with people in a family system, educating the family members that trust is earned. And the only way to earn something is to give an opportunity for it to be earned. Right. And so obviously you don't want to send your loved one who's, you know, 2 weeks into recovery, you know, to the bank with your ATM card and, you know, and the access to withdraw as much as they want. Right. But maybe you can send them to the grocery store and ask for a receipt. Right. That way trust can be earned. And yeah, it looks like everything's here. And, you know, and little bits build things back. The other area is potential contact for with vulnerable people, such as children. This is always an interesting one, right? If you're, you know, if the person that you're working with is caring for children or caring for the elderly or caring for a loved one, there's the fear that they would do something wrong or harmful. And, you know, that yes, there is a potential, you know, during active addiction, but once a person's in recovery, what we find is that people tend to be a lot more empathic, right? Because they understand the struggle, right? And again, just like I talked about with trust, we have to be able to have this, earn this back. I get calls all the time from family services, whether it's in Rhode Island, Connecticut, Massachusetts, you know, and they'll ask, is such and such person appropriate to take care of their children? And then I have to question myself. I'm like, am I appropriate to take care of children? There are days when I don't think I'm qualified, right? Parenthood, as we can all attest to, anyone that has children in this room, is the only job that you're totally and completely unqualified for, that you figure out throughout the way, right? But it's also important, you know, when we talk about that sense of purpose, value, and meaning, right? That spiritual development, that we're able to interact back towards that purpose, right? And so people, you know, have to earn that purpose back, have to earn that meaning back in their life, and be able to support their loved ones, support the people that they care for and that they provide care for in their life. The potential for self-harm. Interestingly enough, and some of you may or may not know this, but most self-injurious behavior, whether it's suicide or cutting or any type of or attempt, is typically done while a person is under the influence. But the rates are no higher for those with addictions than those without addictions. Now, the reason why people are typically under the influence is because human beings have two basic drives, right? Two fundamental basic drives: survive and reproduce, right? So in order to hurt oneself or to try and take one's own life, it's almost impossible to do it without, not impossible, but it's very difficult to do it without inhibiting your sense of awareness, right? And so substances are almost always on board whenever a person is engaging in self-injurious behavior, but the rates are no different for people who have addictions versus those who do not, right? Yes, substances are present, but it doesn't necessarily mean that it's more likely that a person who is a substance user will do so. The next one I find very interesting, right? And this research may have changed since 2013. But you know, that the fact that mental illness is antithetical to power and authority, right? That people with mental health or substance use issues shouldn't be in power. I don't know if any of you have been paying attention to politics over the last, 40 years, but like pretty much that's all we vote in right now is people who are probably not mentally stable. So it's really important for us to understand that, you know what, there are people throughout every walk of life, every stage and tier of this world, who are struggling with mental health, who are struggling with substance use, who are in recovery, that, you know, that have power and authority over everything in our life, right? And that, you know, just because a person is, you know, has a history with substance use, has a history with mental health, does not mean that they can't be in a position of authority, does not mean they can't be a great supervisor or a great leader. Oftentimes we see it, and Steph can point to, you know, can attest to this as well, is that those people tend to be much more compassionate, much more empathic, and much more understanding because of the lived experience that they can bring to their interactions with the people that they're supervising, that they have authority over. And finally, uneasiness about how to interact with people with mental health or substance use. And I always find this so interesting because I'll have people that'll ask me, right? I'll have friends and family members like, how do you like, what do you like do around people who are like, you know, like using drugs or like, or in recovery? Like, what do you like, what do you do? How do you talk to them? Like, what do you offer them when they come over your house? Like, obviously you can't like say, do you want a drink? I'm like, yeah, because like every drink has alcohol in it, right? And they're like, well, I mean, you know, and so like I said, you know, I always tell them, just treat them like they're regular people. And they're like, what do you mean? Because I said, because they are regular people, right? Like they're, you know, it's always so strange, right? And whenever, you know, I always tell people like recovery, how people want to be treated once they enter into recovery is uniquely individual to that person. Some people may not give two cares in the world if you ask them if they'd like a glass of wine or if you drink a glass of wine in front of them. Others may be absolutely mortified and would never talk to you again if you did it, right? But you'll never know if you don't ask, right? It's always better to ask, right? It's, you know, ask first. You're not going to hurt anybody's feelings by asking them. And if you do, that's something that they can take up with their their sponsor or their therapist or whatever else. But it's always better to ask, hey, would you like to, is this okay? Are you comfortable with this? Let them tell you what they're comfortable or not comfortable with. I think the thing that makes people most uncomfortable is when they get totally disconnected, when they're no longer invited to parties, to social gatherings, to dinner, to whatever, you insert event here, because I don't know what to do. And normally we drink at cookouts, but now you don't drink and I don't know what to do. So I'm just not going to invite you, right? Like, that is disconnecting, right? That uneasiness drives stigma, right? And that's a covert, you know, stigma, like, oh, well, I don't know what to do, so I just won't talk to you. It's better to ask the person or say, hey, there's going to be a lot of drinking here. Are you sure you want to be here? Hey, there's going to be, you know, whatever, that, you know, and allow that person to make that decision. Any questions about anything I've talked about so far?
Not right now, Chris.
Okay. So I want to skip ahead because I want to be mindful of the time. There's a couple of slides towards the end that I wanted to talk about. So what can we do as case managers to support a stronger recovery-oriented community? So first and foremost, appropriate language, right? Person first, strengths-based. We talked about that. Create a recovery-friendly environment. Right. And this can happen in various different ways, right? We talk about, you know, Steph and I at work, we celebrate recovery achievements, right? What's one of the first things we do to every patient that comes in once we look at their face sheet? What do we put on the calendar, Steph?
Their birthdays.
Why do we put their birthday there?
I think it's important to celebrate the things that maybe they haven't been, or maybe no one has in their life.
Yeah, in a healthy way.
Right, exactly. Yep, and relearn how to celebrate, relearn, you know, how to do things without substances or alcohol.
Yeah. And it's interesting because sometimes we'll have people and they've been there for 3 days and their birthday is 3 days after their admission date. And, you know, we get a card and we get a cake and we have everybody sign their card and they get a card signed by 47 people that they've never met in their entire life. And there's a cake for them when they come out after the second group before lunch. And you see people like in tears that like, wow, nobody's talked to me about my birthday. I haven't remembered a birthday. You know, I was going to totally forget my birthday. You know, those little achievements, those normal everyday activities. We celebrate recovery anniversaries, obviously. We create an environment that supports recovery, right? We offer additional support groups that, you know, within the facility. We offer extra resources. We offer snacks and a comfortable environment. And I think those little things, and Steph deals with this a lot more than I do, those little quick conversations and those check-ins. And when someone walks through the door, rather than just pointing them to the group room, asking them how they're doing, you know, like commenting on how much you like their shoes, asking them how their dog's feeling because they told you they had to leave yesterday early because their dog was sick. Those things are essential in creating that environment. You know, and then finally, recognizing and normalizing challenges. And as you know, and I know for our case management department, that's one of the things that's so difficult. You know, is we have people that come in and they're working on short-term disability or long-term disability, and they're working on SNAP, and they're working on food assistance, and they're working on they're working on getting appointments for, you know, follow-up for care that they haven't done in 20 years. And it's not easy. Right. If it was easy, they wouldn't need us to help them do it. And so Steph and our team does a great job of normalizing these challenges and normalizing these barriers and not dismissing them and not saying, don't worry about it. You know, you'll get your check eventually. Oh, don't worry about it. This happens to everybody. But saying, yeah, this is hard. And, you know, we're here with you and I'm working on it, and updating them throughout the process on like, hey, this is where it's at. It's been faxed over. This is happening. I'm on top of it. Right? Like, you worry about you, let us worry about the things that we can help with. And I think, you know, Steph, if you have anything you want to add to that and how that process works for you and what we've done to kind of support people there, that'd be great.
I feel like every time that I meet a new person coming through the door, I remember my first day. And I remember I didn't know that recovery was like this. It's a comfortable place where you come in, you don't feel less than, you don't feel like you're being punished, which is what I thought recovery would be. And I found the opposite, and I was shocked, pleased, but I was also scared. You know, it's your first time through the door, and I try to remember that with every person that I interact with. And just let them know you did the hardest thing already. You walk through the door. And what do you need? What can I help you with? And I think addressing people honestly, sincerely, looking them in the eye and treating them like a human is something that could mean the world to somebody. And also letting them know I've been there. I'm empathetic. I get it. And how can I help you? Because my life has changed so drastically, and I would love to see that in other people. And a lot of times we see people in the beginning starting off so, you know, distraught and feeling so terrible, and then by the end they're different people in a great way. They're more themselves, is what I should say. So it's really rewarding. And I just want to make that experience great for them, like it was for me.
Excellent. So that is it. I want to be mindful of the time. I know I was going to save a couple minutes for questions and answers. Does anybody have any questions? Has anything come up so far?
Anyone can put their questions on the Q&A or in the chat if you can't find the Q&A button. Great presentation, Chris and Stephanie. Thank you so much.
You're welcome. There is
have any questions? How long? There's a question from the chat. How long is the wait to get into your facility? And another question, more ideas for what family members can do.
Sure. So in terms of the way to get into our facility, it's typically same day or next day. Once the phone call is made, a pre-admission screening phone call is done over the phone, and we schedule admission for as soon as possible. We know that the window of willingness for help usually closes very quickly, so we try to get that person scheduled right away. And then we, even before they come in, we're following up with outreach on like, hey, we'll see you tomorrow, 8:30, 9 o'clock, you know, like to confirm. But there is no wait. In terms of Anne's question, more ideas for family members. One of the things I always try to remind family members is that if, you know, addiction is a family disease, and by the time it reaches the stage that it's by the time it's reached a stage where a person is ready to get help, it's already, it's infected the family as well. And so not only is that person needing help and support, but the family does as well. Family members could benefit from education, from support, right? So education on what addiction is, what addiction isn't, what recovery is, what recovery isn't, as well as the ability to process, like what can happen in recovery, and just the opportunity to talk about it with other people. One of the things I hear from family members all the time is like they have their own post-traumatic stress from the phone ringing, right? And the phone rings after 8 o'clock at night, and every time they think it's going to be the time when they get the call that their loved one has done something to hurt themselves, or done something, or gotten into a car accident, or overdosed. And so, have they had an opportunity to talk about that? Because talking about your loved one's addiction isn't water cooler conversation at work. So education and support. The more education, the more support, and the more that family members understand that recovery is not just for their loved one who's identified as the patient, but for them as well.
As a follow-up, Chris, does Ocean State Recovery provide services for families?
Yeah, actually, we have a family group that meets what night, Steph?
Monday nights, 5:30 p.m.
Yep. And it's open to the community. It's not specific to our patients. So any family member, we just ask that you call and let us know so that we make sure that we have enough room. But we typically have anywhere from 10 to 20 people that's there. It's led by a licensed clinical social worker who facilitates the group, but we really let the group kind of facilitate itself. We're just there to kind of move through the process and provide some professional education and support. But it belongs to the family members.
Another question in the chat is, have you ever come across any sickle cell patients? Because she works with patients of sickle cell disease who become dependent on opioids. And because that is the only treatment for pain.
Because of the
answer that, Steph.
We have come across patients with sickle cell, and I know I have in my career. And again, we try to find, different options to manage the pain, because yes, the opioids are going to probably be indicated, or may continuously be indicated throughout, but how and what those opioids are can be managed differently. We may look at things like buprenorphine as opposed to a short acting opioid like oxycodone or something like that.
One other question is, my team is finding it so difficult to manage patients who don't mean to become addicted, but unfortunately do. That's a statement. Yep. How do you deal with the high relapse rate in the people with addiction? I work in an acute hospital. We pour our hearts out into people and families, then wait for the patient to show up in the hospital again. And then up to that is, do you take out of state insurance, Mass, Connecticut, Medicaid, Medicare?
So I'll answer the first question first in regards to how we deal with the high relapse rate. We deal with the relapse, and so, I mentioned earlier, 40 to 60%, right? The same thing as hypertension, diabetes, and asthma. We understand that relapse can happen. But whenever a person comes to us and they said they've had a relapse, I try to reframe it from a negative, right? Because again, with addiction, we focus on it so negative. I try to reframe it the same way that you would with a patient who had hypertension, diabetes, and asthma, and say, okay, this happened. What can we do differently, right? What can we do differently? And educate the patient on what was different. What can we do differently this time? And every time we try to make an adjustment, whether it's adding in supportive sober living, increasing social supports, trying a new medication, or maybe reevaluating the medications that they're on, we try to make sure that we're making adjustments, right? And it's hard, right? Because sometimes the patients are, I don't know about that, I'm not sure about that, and I've tried that before, like, I had a cousin that did that and he didn't like it, and it's like, okay, but we need to do something differently. The definition of insanity is doing the same thing over and over again, expecting the same results. So we always try to advocate for our patients and support them in making changes to adjust their treatment, and reframing a relapse as, hey, you know what, something happened, but it's not necessarily that bad. We can work through it. We do take out-of-state insurance in our Massachusetts and Connecticut facilities. Massachusetts, Rhode Island, and Connecticut, we do have contracts with state Medicaid. In Rhode Island, we take every insurance, including Medicare, Medicaid. But we can only take Medicaid in the state in which we exist. So Massachusetts, we can take Mass Health, certain Mass Health products. In our Rhode Island facility, we can take Rhode Island Medicaid. In Connecticut, we can take Connecticut Medicaid, but we can't transfer them out of state because they have to, those monies are capitated within the state. And then all other commercial insurance we accept. All right. Any other questions?
Chris, really engaging presentation.
Thank you. I appreciate it.